This is Dr. Chris Robertson providing an overview of pneumonia. By definition, it is an acute inflammation of the lung, usually infectious in nature. This is when the alveoli fill with exudate, which causes the consolidation. With pneumonia, you do have an increased mortality among older adults, particularly with underlying pulmonary disease. Community-acquired pneumonia, which does need to be distinguished from nosocomial pneumonia, occurs outside the hospital or is diagnosed by day 2 in a hospitalized patient that does not have a history of long-term care facility residence 2 weeks prior to the hospitalization. Keep in mind that with older adults, 1 in 10 leading causes of mortality is due to pneumonia and is frequently a terminal event in older adults and those with debilitated chronic disease, particularly respiratory chronic disease. So it's very important that we recognize and treat appropriately, follow up, manage, monitor in our older adult population. One of the things to keep in mind with pneumonia, already spoke about there being community acquired and nosocomial. With community acquired, which is what you will see more so in the primary care setting, keep in mind that you have typical community acquired pneumonia and atypical, specifically speaking to the pathogens, having typical pathogens versus atypical pathogens. That is important because that drives the treatment choices. Typical pathogens are listed here. It's important that you recognize the most common, which is S. pneumoniae, which needs an N and E at the end of it. That is a gram-positive cocci. You also have H. influenza, which is a gram-negative coccobacillus. You also have the other typical pathogens that are listed, along with what you would expect to see on gram stain. When you look at the atypical pathogens, recognize that mycoplasma is largely the most common. The one that we hear about the most is also called walking pneumonia. You also have C. pneumonia, which both are gram negative. Keep in mind with atypical community-acquired pneumonia, you have a more gradual onset of symptoms. These are patients who may have a dry hacking cough that may have occurred over a longer period of time versus someone who comes in with new onset coughs, which was sudden onset, and a temperature, and they've only had symptoms for a couple of days, versus someone who has had a fever and a gradual onset of symptoms over a week or so or more, as well as other constitutional symptoms, which you do see with pneumonia. Here are some of the nosocomial typical pathogens, which are mostly caused by gram-negative organisms. Again, it's important to recognize that because when you're looking at gram stain, you want to have an idea of the organism that you may be treating. So those are listed here. And be attentive to the ones that are most frequently reported among elderly nursing home residents. And let's go back for a moment, also noting that, yes, MRSA, gram-positive cocci, is one of the nosocomial typical pathogens. With respect to pneumonia, there are typical pneumonia syndrome or symptoms that you will see, subjective findings as well as your findings from physical exam. So you want to be mindful of what those are. Keep in mind that with older adults, they may often present with weakness, mental status change, or perhaps a history of fall. With respect to chest x-ray, which is a diagnostic tool that can be used. On chest x-ray, you typically have findings of lobular infiltrates, which will suggest bacterial infection versus viral. However, when it comes to your chest x-ray, you may or may not opt to do a chest x-ray. It depends. Some of that may be driven by the health system that you're in and what their policy is, if the chest x-ray is done on site versus if the patient has to go somewhere else to have it done. Other diagnostics that you may see used would be loop count. So if there was a CBC done, you would be able to look at your white blood cells. Obviously, over 15,000 or over 15 would suggest a bacterial etiology. And again, this helps you distinguish between bacterial and viral pneumonia. There is mention here about consideration for a chest x-ray after treatment to ensure infiltrates are clear. However, that's something that I'm going to bring up when we're talking more about follow-up. Again, with diagnostics, you have your sputum gram stain, which is really the only diagnostic tool available at therapy onset when you're looking to specify the bacteria or the pathogen that you suspect is causing the pneumonia. The biggest issue with sputum gram stain is that it's often contaminated with large numbers of epithelial cells. And so, again, looking at the gram stain, knowing is this a gram-positive cocci, gram-negative, whatever. But that gram stain will give you an indication about, again, what pathogen you're treating. When it comes to the culture, they're definitely less valuable, but only because it's very challenging to actually get a culture. 50% of patients with negative cultures may have large numbers of organisms present on gram stain. So again, that's why when patients that do have pneumonia, if you're going to rely on something to specify what type of organism, is going to be your sputum gram stain. Keep in mind, sputum induction is not something that you would necessarily be doing in the primary care setting. That is more appropriate for patients who are hospitalized or patients who are severely ill. So again, here you can see the table or the box from the text that shows the sputum staining that can be done or performed and what type of results. With regards to pneumonia treatment, as a primary care provider, the biggest concern is, can I treat this patient outpatient or do they need to be hospitalized? CURB 65 is one of the criteria used for community-acquired pneumonia. It is essentially a tool that you calculate based on the clinical factors, which are assigned a point value, and you determine the score. Based on the score, you determine if the patient can be treated outpatient at home or if they require some type of hospitalization, or if they're kind of in between, if you're concerned about them needing a short stay or if they can be closely monitored with outpatient treatment. So it does help you distinguish. And as you can see, there are factors, specific factors, that you need to be able to calculate the score. Obviously, if you do not have a BUN, then this would not be an appropriate tool to utilize. In which instance you would be able to use something like the Pneumonia Severity Index calculator. And this would, again, is something that you could use, have it saved or bookmarked in your internet browser. But you're able to answer the questions based on the patient's information and determine their risk, their score, and if they meet or they fall within the category for outpatient treatment or if they're going to likely require when making a decision about outpatient treatment or hospitalization. When it comes to how you actually treat community acquired with respect to antibiotics, you definitely want to consider, is this person previously healthy or do they have comorbid conditions? You also want to take into consideration, are they immunosuppressed, which we typically associate with comorbidities. The other thing is, has this patient been on antibiotics within the past 3 months? Those are the 2 or 3 considerations that drive treatment options, or at least initial considerations for treatment options. And so here you see what your options are with previously healthy, no antibiotics in the past 3 months, versus persons who have comorbidities or immunosuppressed or have been on antibiotics within the past 3 months. I also want to point out that when you get to which regimen specifically that you're going to use for patients, understand that that is influenced by insurance coverage. Levofloxacin, or Levaquin is going to be much more affordable than moxifloxacin or Avelox. It's also influenced by medication allergies as well as medication interactions, and also length of treatment. If you have a patient that you know is not going to take a regimen for 10 days, and particularly if it's twice a day, and they will have much better adherence with a regimen that is once daily for 5 days, that will also influence your choice. I inserted this to show how you're able to also use the Hippocrates tool. Hippocrates is an app. They do offer a free version, and there also is a paid subscription which gives you access to all of the features offered through this product. Even with using the free version, you have access to medication so that you can go and look up dosing information. You can look up any type of contraindications or cautions, adverse reactions. It gives you the most common things that you need to discuss or inform your patient about, as well as some of the more serious side effects that they would need to monitor for. Also lets you know any type of major drug interactions, safety issues, pharmacology. I sometimes look at those to look at the medication's half-life to determine when the patient may begin to see effect and when I should anticipate improvement. However, know that Hippocrates is a resource available to you to help inform your decision making. And you see here, when you look up azithromycin, it is used to treat community acquired pneumonia. It gives you the dose and the regimen, and also gives you alternative dosing if needed. When it comes to patient education with pneumonia, one of the biggest things to point out is immunization, making sure that patients are properly immunized. Of course, this is more on a prevention perspective. However, it's important to recognize this in your patient population. And also with older adults, immunizations that they should be receiving, it's typically underutilized. So we need to make sure that when it comes to the 2 vaccines, the Prevnar as well as the Pneumonivax, we need to make sure that we are having conversations with patients that this is applicable to. This is a resource that tells you about the 2 vaccines that are recommended for adults, the Prevnar and Pneumovax. And so it's important to realize that both are not given during the same visit, and that if you have an older adult who's not received either, you want to give Prevnar first and then give Pneumovax second. And it also indicates and gives you the information, because typically it is 65 and older, but for persons who are 19 and older and have certain medical conditions, we need to make sure that that vaccination is considered for those persons as well. So do refer to this as a guide for vaccine considerations. And again, this gives you information about the timing for adults that are 65 and older when it comes to those two vaccines. How much time should be in between those two and who should be getting them. As another digital reference or way of using technology, you have the CDC vaccine schedules, which is an app that can be downloaded on a tablet or phone. You can also save the page on a web browser, bookmark it as well. However, this gives you up-to-date current information about immunization. So if you're looking for something specifically, you can go into the app, click on Prevnar, and see exactly what you need to know about who should receive it, when they should receive it, and what considerations should be given, even with regards to the Pneumovax vaccine as well. When it comes to follow-up and referral of patients that are being treated for pneumonia, typically no close monitoring or follow-up is needed unless symptoms worsen in spite of antibiotics. Typically, you want these patients to begin improving over at least the first 48 hours, and if not, you want to hear from them. These are patients that at a minimum would have the nurse or medical assistant calling to check on them to make sure that they're feeling better. If you have a patient who has worsening symptoms or failing to improve, these patients I'll typically see back in the office because I want to see, can I continue outpatient treatment, of course, of changing the regimen, or are you going to require hospitalization? Obviously, if it's outpatient treatment, we're going to change the antibiotic. And again, I would still want to see these patients in the office in about a week to make sure that they are continuing to improve. And when you see them in a week, you're assessing their response to the antibiotic change. Obviously, when you change the antibiotic, if they're not improving within 2 days, you want to hear from them, even on the phone. And when you see them in the office, you want to make sure that they're at a place, depending on the regimen, if it wasn't a 5-day regimen, if it was a 7 or 10-day regimen, that you're still able to continue outpatient treatment versus hospitalization. If there's a need for a 4 to 6 week follow-up office visit, at this point, depending on what's going on with the patient, again, if they have comorbid conditions or if they're immunocompromised, a visit may be indicated. Some providers will get a follow-up chest x-ray at this point to ensure resolution. And with regards to what you should expect, 50% of patients will have resolution at 2 weeks and 75% of patients will have resolution after 4 weeks. And that concludes the segment for pneumonia.